Hello, I'm Dr. Helen Brooks, and if you or someone you love is over 65, I need 8 minutes of your time today, because what I'm about to share isn't fear-mongering, it's not a scare tactic, and I'm not going to tell you to throw away your pills the moment this video ends. What I am going to do is walk you through some of the most well-documented research linking certain everyday medications to memory decline in older adults. Research published in real, respected medical journals, conducted by real universities and reviewed by real scientists. My goal isn't to frighten you. It's to arm you with the right questions to bring to your doctor or your pharmacist, because that conversation, the one where you actually ask, "Is this medication affecting my brain?" is a conversation millions of families never think to have. Before we get into the specifics, I want you to picture something. Think of an ordinary kitchen counter or a nightstand drawer in a typical American household where someone is over the age of 70. There's usually a blood pressure pill, something for cholesterol, maybe something for sleep, an allergy pill from the drugstore, and something for an aching back or restless legs. None of these feel dangerous. None of them come with a warning label that says, "This may affect your memory." They were prescribed one at a time over years, often by different doctors treating different problems, and most people never step back and look at the whole picture at once. That's really what this video is about. Not any single villain medication, but understanding what the research actually says, so you can have an informed, calm conversation with the people who manage your care. Let me start with the single largest study on this topic, because I think it deserves your full attention before we go any further. In 2019, researchers at the University of Nottingham, led by Dr. Carol Coupland, published a study in JAMA Internal Medicine, one of the most respected medical journals in the world. They looked at the health records of nearly 285,000 people over the age of 55 in the United Kingdom. 58,769 of them had been diagnosed with dementia, and just over 225,000 had not. The researchers went back and examined what medications each group had been taking in the years leading up to diagnosis, specifically looking at a category of drugs called anticholinergics. What they found was this: people with the very highest cumulative exposure to strong anticholinergic drugs had roughly a 49% higher risk of developing dementia compared to people who took none at all. People with lower exposure had a smaller increase, around 6%, and the researchers estimated that if this relationship is truly causal, about 10% of dementia diagnoses in their data could potentially be attributed to anticholinergic drug exposure. That's not a made-up number. That's not a shock statistic invented for a video. That's what appeared in the pages of JAMA Internal Medicine, one of the most cited medical publications on Earth. Now, before I go any further, I want to explain what anticholinergic actually means, because you're going to hear this word several times today, and understanding it will help everything else make sense. Your brain relies on a chemical messenger called acetylcholine. It's involved in memory formation, alertness, muscle control, and a whole lot more. Anticholinergic drugs, as the name suggests, block the action of this chemical to varying degrees. Some medications have very mild anticholinergic effects. Others have very strong ones. And the concerning part, the part researchers keep circling back to, is that many older adults are taking 2, 3, sometimes 5 or more of these medications at once, often prescribed by different doctors who aren't necessarily talking to each other. Each one on its own might seem harmless. Together, the cumulative burden on your brain's acetylcholine system can be substantial. This idea even has a name in geriatric medicine, anticholinergic burden, and it's one of the most quietly important concepts in the entire field of aging and cognitive health. It's also worth understanding why older brains seem to be more vulnerable to this effect than younger ones. As we age, several things change at once. The blood-brain barrier, the protective filter that keeps many substances out of the brain, becomes somewhat more permeable, allowing more of certain drugs through. The liver and kidneys, which are responsible for clearing medications out of the body, generally slow down with age, meaning drugs can linger longer and build up to higher effective levels than they would in a younger adult taking the exact same dose. And the brain's own supply of acetylcholine, the chemical we discussed, naturally declines somewhat with normal aging, even without any disease process involved. So a medication dose that a 40-year-old tolerates easily may have a meaningfully stronger effect on the brain of an 80-year-old simply because of these underlying physiological changes. This is part of why the American Geriatric Society updates its Beers criteria list every few years, specifically to help doctors and pharmacists identify medications that carry disproportionate risk in older patients, even when those same medications are considered perfectly reasonable for younger adults. So let's go through some specific categories where the research is genuinely well established, and I'll tell you honestly where the science is strong and where it's still being debated, because intellectual honesty matters more to me than drama. Let's start with something sitting in almost every household in America: diphenhydramine, the active ingredient in Benadryl, and in most PM nighttime sleep aids like Tylenol PM or Advil PM. This is one of the oldest and strongest anticholinergic drugs still widely available over the counter. It's used for allergies, colds, and as a sleep aid, and it's often the very first medication people reach for without ever thinking of it as a drug in the same category as a prescription. But pharmacologically, it absolutely is. Multiple studies, including work referenced by the American Geriatric Society's Beers criteria, a widely used clinical guideline for medications that carry higher risk in older adults, list diphenhydramine as a medication that should generally be avoided in seniors, specifically because of its strong anticholinergic effects and links to confusion, falls, and cognitive impairment. If you're taking a nightly Benadryl or a PM product to help you sleep, that's genuinely worth a conversation with your doctor. There are non-anticholinergic alternatives, like the newer generation antihistamines, such as loratadine or cetirizine for allergies, which don't cross into the brain the same way, and options like melatonin or cognitive behavioral therapy for insomnia, which has strong evidence behind it for long-term sleep improvement without any cognitive burden at all. Next, let's talk about bladder control medications, specifically a class called antimuscarinics, which includes oxybutynin, sold as Ditropan. This one is important because oxybutynin is considered one of the more strongly anticholinergic drugs still commonly prescribed to older adults, and it crosses into the brain quite readily. The Nottingham study I mentioned specifically identified bladder antimuscarinics as one of the drug categories with a significant association to increased dementia risk. That doesn't mean overactive bladder shouldn't be treated. It absolutely should. Incontinence has enormous effects on quality of life and dignity. But it does mean this is a very reasonable topic to raise with your doctor. Newer medications like mirabegron, sold as Myrbetriq, work through a completely different mechanism, one that doesn't block acetylcholine at all, and are generally considered a gentler option for older patients from a cognitive standpoint. Now let's talk about something that surprises almost everyone: proton pump inhibitors, or PPIs, medications like omeprazole and esomeprazole, sold as Prilosec and Nexium, used by millions of people daily for acid reflux and heartburn. In 2016, a large German study published in JAMA Neurology, led by researcher Willi Gom, followed over 73,000 adults aged 75 and older and found that regular PPI users had a meaningfully higher incidence of dementia diagnosis compared to non-users. It's important that I'm honest with you here. This research area is genuinely mixed. Other studies, including some more recent ones, have found weaker associations or none at all once you account for other health factors, and a Mendelian randomization study, a method that tries to get closer to establishing cause rather than just correlation, has produced inconsistent results. What we do know for certain, without any controversy at all, is that long-term PPI use can interfere with the absorption of vitamin B12, and B12 deficiency is a well-established, very well-documented cause of memory problems, confusion, and cognitive decline in older adults, one that is often reversible with supplementation once it's caught. So even setting aside the more debated dementia research, if you've been on a PPI for years, it is absolutely worth asking your doctor to check your B12 levels and asking whether you still need to be on the medication at the dose you're taking, or whether stepping down to an H2 blocker like famotidine, sold as Pepcid, might be appropriate for you. Let's move to a category that affects nerve pain, depression, and sleep all at once: tricyclic antidepressants, particularly amitriptyline, sold as Elavil. This is one of the oldest classes of antidepressants still in use today, largely because it's inexpensive and genuinely effective for certain kinds of chronic nerve pain and migraine prevention. But it is also one of the most strongly anticholinergic medications still in common circulation. A widely cited 2015 study published in JAMA Internal Medicine, led by Shelley Gray and colleagues at the University of Washington, followed over 3,400 older adults for an average of about 7 years and found that higher cumulative use of strongly anticholinergic medications, amitriptyline among them, was associated with a significantly increased risk of developing dementia. This is one of the better established findings in this entire field. If you're taking amitriptyline for nerve pain or as a sleep aid, know that there are alternatives your doctor may be able to offer, including gabapentin or duloxetine for nerve pain, and non-anticholinergic options for sleep that carry a much lower cognitive burden. Now here's one that even many pharmacists don't flag quickly enough: paroxetine, sold as Paxil. Paroxetine belongs to the SSRI family of antidepressants, generally considered a much gentler, more modern category than the tricyclics we just discussed. But paroxetine is the outlier within its own family. Because of its chemical structure, it has meaningfully more anticholinergic activity than other SSRIs like sertraline or escitalopram. This is exactly why the American Geriatric Society's Beers criteria specifically flags paroxetine as a medication to generally avoid in older adults, while it does not flag most of its SSRI siblings. If you or someone you love is on paroxetine, this is one of the more clear-cut, low-controversy conversations to have with a prescriber because equally effective alternatives with a much lower anticholinergic footprint typically exist. Let's talk about benzodiazepines now, medications like lorazepam, diazepam, and alprazolam, sold as Ativan, Valium, and Xanax. These aren't classified as anticholinergics. They work on a completely different brain chemical called GABA. But the research connecting long-term benzodiazepine use to cognitive decline in older adults is substantial and taken very seriously in geriatric medicine. A widely discussed study published in the BMJ followed thousands of older adults and found associations between sustained benzodiazepine use and increased dementia risk, particularly with longer-acting versions of the drug that stay in the body and therefore the brain for extended periods. I want to be especially careful here because this is genuinely one of the more dangerous categories to stop cold turkey. Benzodiazepine withdrawal in older adults can cause severe rebound anxiety, seizures in some cases, and serious complications. So if you've been on one of these medications for more than a few weeks, please do not stop suddenly on your own. This absolutely requires a slow, medically supervised taper, and that's a conversation to start with your prescriber, not a decision to make after watching a video. I also want to spend a moment on antipsychotic medications, drugs like quetiapine, risperidone, and olanzapine, sold as Seroquel, Risperdal, and Zyprexa. These medications were developed for serious psychiatric conditions like schizophrenia and bipolar disorder, but they are sometimes prescribed off-label in nursing homes and hospitals to manage agitation or behavioral symptoms in people who already have dementia. This particular practice, prescribing antipsychotics for behavioral symptoms in dementia patients, has drawn serious scrutiny from regulators and researchers alike, including an FDA black box warning about increased risk of death in elderly dementia patients treated with these drugs, and research published in respected journals linking their use to faster cognitive and functional decline in this specific population. If a parent or loved one with dementia has been placed on one of these medications, primarily to make them easier to manage, it is entirely appropriate, and I'd encourage you to ask the care team directly why, whether non-drug approaches have been tried first, and whether the medication is being reviewed regularly rather than continued indefinitely out of convenience. Before we get to statins, I want to touch on one more category that doesn't get nearly enough attention: opioid pain medications, drugs like oxycodone, hydrocodone, and tramadol, commonly prescribed after surgery for chronic back pain or for arthritis in older joints. These aren't anticholinergic in the same way as the drugs we've discussed, but they act directly on the central nervous system and are well known to cause sedation, confusion, and short-term cognitive impairment, particularly in older adults, whose bodies process and clear these medications more slowly than younger adults. Research published in Geriatric and pain medicine journals has repeatedly shown that opioid use in older adults is associated with increased fall risk, delirium, especially around hospital stays or surgery, and, with long-term use, an association with cognitive decline, although this research is complicated by the fact that chronic pain itself is also independently linked to cognitive difficulties. This is precisely why untangling cause and effect in this field is genuinely hard, and why I keep using words like association rather than proof. What we do know clearly is that if a senior in your life seems suddenly foggy, unsteady, or not themselves after starting a new pain medication following a surgery or an injury, that is worth flagging to the medical team immediately because it may be treatable simply by adjusting the dose or the type of medication, and it's often mistaken for a sudden step down in someone's baseline health when it's really a medication effect. Now let's talk about statins. Medications like simvastatin and atorvastatin, sold as Zocor and Lipitor, used by an enormous share of older adults to manage cholesterol and reduce cardiovascular risk. Here I want to be very clear with you. This is one of the more contested areas in this entire discussion. Some earlier observational studies raised concerns about statins and memory complaints, but larger, more rigorous reviews, including analyses referenced by the FDA after it revisited its own labeling on this topic, have generally found the evidence for statins causing long-term cognitive decline to be weak, and several major studies have actually found statins associated with a lower risk of dementia, likely because of their cardiovascular benefits, since heart health and brain health are deeply connected. Some people do report short-term memory fog when starting a statin, and that's worth mentioning to your doctor, but the overall picture here is far less alarming than some corners of the internet suggest, and I did not want to overstate this one just to keep a list looking dramatic. I also want to briefly mention anti-seizure and nerve pain medications like gabapentin and pregabalin, sold as Neurontin and Lyrica, because prescriptions for these have risen sharply over the past decade, partly as doctors have looked for alternatives to opioids for chronic pain. These medications aren't anticholinergic either, but they do act on the central nervous system, and in older adults, they're associated with sedation, dizziness, and in some studies, with confusion severe enough to be mistaken for early dementia, particularly when combined with opioids or benzodiazepines, a combination that several health authorities have specifically warned about because the sedative effects can compound each other. Again, this doesn't mean these medications are wrong for you. For genuine nerve pain, they can be enormously helpful and are often safer than long-term opioid use. It simply means that if you're on one of these and you or your family notices new confusion, slower thinking, or unusual drowsiness during the day, that's useful information to bring back to the prescriber because dose adjustments often resolve it entirely. Which brings me to what I think is genuinely the most important point in this entire video, more important than any single drug on this list. It's the cumulative anticholinergic burden of taking several of these medications at once. This is sometimes called polypharmacy, and it's an enormous focus in geriatric research right now. Picture a fairly ordinary scenario. Someone taking an over-the-counter sleep aid at night, a bladder control medication during the day, and an older antidepressant for nerve pain, 3 medications, each prescribed by a different provider, none of whom may realize what the others prescribed. Individually, each drug might carry a modest anticholinergic load. Together, that load can become substantial, and this is precisely the mechanism the Nottingham researchers were measuring when they looked at total cumulative anticholinergic exposure rather than any single drug in isolation. The encouraging part of this story, and I promise you there is an encouraging part, is that this is often addressable. There are tools called anticholinergic burden scales that pharmacists and geriatricians use to calculate a person's total anticholinergic load across every medication and supplement they're taking, prescription and over-the-counter alike. A thorough medication review, sometimes called deprescribing when it results in safely reducing or switching medications, is one of the most evidence-based interventions available in geriatric medicine today, and in some cases, cognitive symptoms that were attributed to normal aging have improved after unnecessary anticholinergic medications were reduced or replaced. So here's what I'd like you to actually do with everything I've shared today. First, do not stop any medication on your own, especially not benzodiazepines or antipsychotics, which can be genuinely dangerous to discontinue abruptly. Second, make a complete list. Every prescription medication, every over-the-counter product, every supplement you take regularly, and bring that full list to your next appointment with your doctor or pharmacist. Third, ask directly, "Can you tell me if any of these medications have anticholinergic effects, and is there a lower-risk alternative available?" That single question, asked out loud, in a real appointment, is worth more than any list a video could ever give you, because your doctor knows your full medical history, your other conditions, and what trade-offs actually make sense for you specifically. If it helps, here are a few more specific questions worth bringing to that appointment. You might ask, of everything I'm taking, is there one medication you'd flag as the highest priority to review first? You might ask, is there a lower dose of this that would still manage my symptoms? You might ask, if we do change something, how will we know within a few weeks whether it's helping or not? And if you're the one caring for a parent, it's worth asking directly, who is the one doctor keeping track of everything they're taking? Because very often, the honest answer is nobody, and that gap is exactly where problems tend to hide. Many pharmacies also now offer what's called a medication therapy management review, sometimes covered by Medicare, where a pharmacist sits down and goes through every single medication and supplement a person takes, prescription and over-the-counter alike, and flags interactions or unnecessary duplications. If you've never asked your pharmacy whether they offer this, it's worth a phone call, because it's often free and it's one of the most practical steps you can take after watching a video like this one. Some of these medications may be absolutely necessary for you, and the benefit may clearly outweigh the risk. That's a decision for you and your medical team to make together, not something to decide from a video on your phone. I want to spend a moment on something I think gets lost in these kinds of discussions, the emotional weight of this topic for families. If you're watching this because you're caring for a parent and you've noticed changes in their memory or their personality over the past year or two, I know how frightening that is. There's a very natural instinct to want a single clear cause, something concrete you can point to and fix, because the alternative, an illness with no clear cause and no clear solution, feels unbearable. I understand why content that promises a simple, fixable villain, a single pill you can throw away to reverse everything, is so appealing. But I'd be doing you a disservice if I let that instinct lead you somewhere the actual evidence doesn't support. Some medications genuinely do carry meaningful, well-documented risk, and those are absolutely worth discussing with a doctor. Other links are weaker, more contested, or still being actively studied, and I've tried to be honest with you about which is which throughout this video, rather than flattening all of it into the same level of alarm. That honesty, I believe, actually serves you and your family better in the long run than a tidier, scarier story would. I also want to gently say this. If a loved one's memory changes have been sudden or significant or are affecting their daily safety, please don't wait on a medication review alone to explain it. Dementia has many causes, and some memory and thinking changes are due to entirely different, sometimes treatable conditions, like thyroid problems, depression, vitamin deficiencies, sleep apnea, or normal pressure hydrocephalus, alongside neurodegenerative diseases like Alzheimer's. A proper medical evaluation, not a video, not a checklist, is how those get identified and, where possible, treated. Consider this video a starting point for a conversation with a real doctor, not a replacement for one. I know this was a lot of information, and some of it may feel unsettling, but I'd rather give you the real, nuanced picture, including where the science is strong and where it's still uncertain, than give you a simplified, frightening version that isn't fully honest. Your brain health deserves that kind of care and accuracy. If this video helped you understand something you didn't know before, please consider sharing it with someone who could use it, maybe a parent, a spouse, or a friend managing a long list of daily medications. And if you found this useful, subscribe, because we'll keep bringing you real, well-sourced information about healthy aging every single week. Thank you so much for spending this time with me. I'm Dr. Helen Brooks, and I'll see you in the next one.